So, moving on, um, we're going to delve into some interesting case studies. And unfortunately, our colleague Marianne can't be here tonight to go through it, so I will go through it for her. Um, but before we go into the specifics, I'd like to highlight the significant benefits and challenges of non invasive prenatal testing. So, firstly, safety. NIPT only requires a simple blood sample from the mother, eliminating that risk associated with an invasive procedure such as miscarriage or other complications. Secondly, improved accuracy. So, compared to traditional first line biochemistry screening, NIPT delivers more accurate results, enhancing in reliability of prenatal testing. And then finally, cost savings. NIPT reduces the need for a referral to tertiary units or fetal medicine services, leading to more efficient resource utilization and lower overall costs. And this isn't just for the clinicians, this is for patients too. They're not having to travel as far to go and see their clinicians. So while NIPT offers significant advantages, it's equally important to acknowledge its limitations. Firstly, limited scope. The NHS currently provides NIPT screening exclusively for Down syndrome, Edwards syndrome, and Patau syndrome. Um, the positive predictive values for other conditions such as sex aneuploidies remains poor, which means that it's constrained to the broader application. And it's important to note that sometimes these are offered within the private sector. So if private testing has caused confusion or anxiety to women and their families, it's really good to link in with your fetal medicine or screening teams for further advice. Secondly, there are exclusions from screening. So, in certain situations, NIPT cannot be used, and this includes vanished twin pregnancies, a history of an organ transplant, current maternal cancers, triplet or higher order multiple pregnancies. Um, and in these cases, it is unsuitable for those pregnancies. Next is accuracy. So whilst NIPT is highly reliable, it remains a screening tool rather than a diagnostic one. And on rare occasions, false positive and false negative results may occur, warranting cautious interpretation. And then finally, diagnostic confirmation is required. So when NIPT indicates a higher chance, confirmation through an invasive test such as amniocentesis should be offered to ensure that accuracy. So this is just an image to show you that there are the two uh, programs that offer NIPT. So we've got the fetal anomaly screening program, and it integrates NIPT as a secondary screening option. And it's offered for Down syndrome, Edwards, and Patau syndrome. It's offered to women who receive a higher chance result from their combined or quadruple test. In contrast, with the R20, with the R445 entry, this is specifically designed for women with a history of a pregnancy or child diagnosed with the full trisomy. Um, and this pathway acknowledges the increased recurrence risk in such a case and offers NIPT as a tailored option. And with all of these, we still should be offering those women the offer of no further testing, non invasive prenatal testing, or a diagnostic test. And it's important for healthcare providers to identify which pathway is most appropriate for the initial booking appointment. Ensuring this information is accurately gathered and discussed early helps to streamline that care and facilitate that timely access to the most suitable screening option for each patient. So, I just want a moment of consideration before we move on to our case study. As we navigate this, I want to acknowledge that many of us may have personal, professional, or lived experiences related to disability, pregnancy, and termination. And these topics can be deeply personal, and perspectives may vary based on medical, ethical, religious, and personal beliefs. And our aims today is to approach this section with respect, openness, and sensitivity. So if at any point you feel the need to step away, then please do so, to take a moment or reflect. We hope that this space is open, thoughtful, and we appreciate everyone's presence here. So I want to shine a spotlight on Patau syndrome and Edwards syndrome. These are genetic conditions caused by an extra copy of chromosome 13 or 18. And typically, humans have 23 pairs of chromosomes, one set from each parent, making a total of 46. And in trisomy conditions, an extra chromosome disrupts that typical development. So with trisomy 18, which is Edwards syndrome, and trisomy 13, which is Patau's, these are life-limiting conditions, but the degree of impact can vary depending on the specific genetic presentation. Sadly, most pregnancies will, with a confirmed diagnosis, will end in a miscarriage or stillbirth. But for babies born alive, the survival rates are low. These conditions are associated with a range of severe signs and symptoms. Common features include microcephaly, eye problems, cleft lip or palate. There's also variations in hand and foot development, heart conditions, and kidney defects. Feeding difficulties and epilepsy are prevalent, along with severe developmental delays, all of which further impact the quality of the life, affecting the babies. And I just wanted to again put a spotlight on Soft UK, which is a really great organisation that can support families through this. But it's important to have sensitive, multidisciplinary care because it's essential for supporting those families through a diagnosis, perinatal management, and palliative care, recognising the profound emotional and physical challenges these diagnoses may bring to families. So that brings us to our case study. So we've got Anne Jones. She's a paranaut plus one. This is her family, or this is her history. So in her previous pregnancy, she'd had a higher chance combined test, which had identified a higher chance for Edwards and Patau syndrome. She decided to have non invasive prenatal testing, which confirmed a higher chance result for trisomy 18 or Edwards syndrome. She proceeded with an amniocentesis, which then also confirmed that trisomy 18 result, but also had an abdominal wall anomaly on the scan. And Anne made the difficult decision to terminate that pregnancy. So we're now just going to walk through this current pregnancy, and she first meets her midwife, her community midwife, at 9 weeks. She informs that midwife of her previous baby with Edwards syndrome. She reports that she's really anxious about this pregnancy and doesn't want any screening. She just wants a diagnostic test. Now, this community midwife is aware that there is this pathway where actually she could have non invasive prenatal testing instead of the combined screening. But she doesn't feel confident to discuss this with her and refers her to the screening midwife. And the screening midwife sees her quite quickly, and she sits and listens to Anne and her partner's experiences and recognizes their concerns. They are made aware of that R445 pathway, but is also advised, if she would prefer, that she could have no further screening or have an invasive test. And because Anne didn't realise that she could have that NIPT straight away, she felt she needed to go home, and it was really important for her to go home and consider those options. But she came back at 10 weeks and 5 days and had NIPT with a scan. So at 11 weeks and 2 days, Anne is informed that she has received a higher chance result for Patel syndrome and is offered an invasive test to confirm that result. She goes and sees a fetal medicine consultant, where a ultrasound is performed and no anomalies are identified. And Anne is offered an option of a chorion villi sampling, CVS, but she's also offered to wait and have a second scan and amniocentesis later on in the pregnancy. But because of the anxieties that Anne and her partner have, they decide they want that CVS performed on the same day. A few days later, she receives her CVS result and it identifies a possible confined placental mosaicism and is advised to wait for an amniocentesis. At 15 weeks, she has that amniocentesis, and the results show that there is a normal complement of chromosome 21, 18, and 13. And she has a live female infant at 39 weeks and 5 days, so a baby girl. So why did Anne get that false positive result? So there are, whilst I suppose NIPT is very highly accurate, false positive samples or results do occur, and that's due to several factors. It can be because of maternal genetic variants. You've got to remember that we're taking that blood sample from the maternal blood, and that is a mixture of maternal and fetal DNA. You've also got if there was, if the pregnancy was initially a twin pregnancy and one miscarried, sometimes the remnants of that DNA from the lost twin may still be detectable. And there's also technical limitations. Variability in sample quality, DNA fragment sizes, or errors in the sequencing can occasionally occur. And then we've got confined placental mosaicism for what we saw with Anne's case. So, and that's in some cases where the placenta may carry chromosomal conditions that are not present in the fetus, leading to NIPT to pick up an issue that doesn't truly affect the baby. So, we really wanted to just take some key takeaways um, for you leaving this session. It's about acknowledging that previous pregnancy experience. And it shapes, unfortunately, these experiences do shape anxieties and expectations. So, thoughtful discussion early on empowers those families to make informed decisions that align with their individual needs. There are two pathways to offering NIPT, but with the R445 pathway, women can be offered screening as early as 10 weeks gestation. Midwives understand the options at booking ensures that women are offered the correct pathway at the earliest opportunity. However, just want to make it clear we're not expecting midwives at the booking to be experts in NIPT. We just want them to be able to have that fundamental understanding and knowledge of those timely referral processes. Considering timely discussions and informed decision making. So, we sometimes think that women should be telling us immediately what they want, and we should be doing things quickly. In these cases, it's really important to make sure those families have the time that they need to ensure they're making the decisions that are best for their situation and individual needs. NIPT is a screening test, and higher chance results should be confirmed by a diagnostic test because false positive results do occur. That said, false negative results also occur. And in the absence of fetal anomalies on ultrasound scans, amniocentesis remains the gold standard for diagnosis with NIPT. So, really, just looking back at Anne's case, that community midwife did the right thing. She recognised that there was a pathway specifically for Anne's personal case. And she didn't feel comfortable with having that full conversation. She is not a screening midwife, she's not a fetal medicine midwife, and may not feel that that's appropriate for her. And that is absolutely fine. But she knew where to go and where to refer her to. I think it's also about highlighting that even if we do things as early as possible, it doesn't mean that the end of the journey will end early too. So it's just bearing in mind that there are complications, and learning about genetics is not always straightforward. So just to find out more, I've just popped on G Notes, Knowledge Hub for NIPT, and this will just take you to a link to give you a little bit more information about NIPT, and also further links to key documents. And also, again, to highlight SOFT, which is supporting organisation for trisomy 13 and 18, that has some valuable resources and also stories from people living with these experiences, that you can go and see. So I'm going to end there.